Hello, everyone. I'm Siri Vaith, Executive Director of CFRI, Cystic Fibrosis Research Incorporated, and I'm happy to welcome you to this 10th and for now final episode of a question and answer session on COVID-19 and CF with Dr. Rick Moss. Unbelievably, this is the 10th session of questions, and I just want to remind everybody, when we had our first town hall on COVID-19 and CF, we had so many questions that we couldn't get to all of them. We thought we would have one extra Q&A session, and here we are 10 weeks later. And it is remarkable how much more we know, how much more we understand that we do not know, just what an incredibly changing field it has been. And I am so grateful to Dr. Moss, who has led us through this journey down the path to help us understand this incredibly complex virus and its impacts upon our community. So before we get started, because this will be the last of the series, I do want to remind people we do have at CFRI many resources for you: psychosocial support, educational programs, and I really encourage, if you have not gone to our website, to please go to www.cfri.org. As always, I have to note that the information that is shared in this podcast is not meant for your own medical diagnosis or treatment. And if you have any questions or thoughts about your healthcare, please do not make those changes on your own. Please confer with your CF team. And again, today, the date is Wednesday, May 27th. And so the information contained within this podcast is current as of today, May 27th. So we will move on to the questions and turn this over to Dr. Moss. And I just want to say to you personally, I'm so grateful to you for all you have shared with the community. Having someone with such incredible expertise, breadth of knowledge, and sensitivity to our community, this has been a true gift. So thank you.
Thank you.
So my questions, starting off, we always start with the first one, which is the update of how many cases of COVID-19 in the US and the world, and how many fatalities.
Right, so the latest figures for the planet are closing in on 5.75 million cases, of which we have over 350,000 fatalities. So the global case fatality rate is holding steady at about 6.2%. In the United States, we have now almost 1.75 million cases, 1.73 million, and we've passed the 100,000 mark in terms of deaths. So in terms of internationally, we're doing a little bit better with a 5.8 case fatality rate. And I remind the audience that the case fatality rate depends on how one defines cases. Death is a pretty hard number, but even there are many cases where deaths may not be recorded for other reasons. So those figures are somewhat wobbly, but that's approximately what it is. If you look at infection fatality rates, that includes more people being tested and milder cases getting picked up, even asymptomatic people. The consensus seems to be settling around 1% fatality rate overall at the end of the day. And I remind people that that is 10 times the level of flu, and the rate of death is many times the rate that flu has over flu season. So once again, we must hold on to the fact that this is not just another kind of flu.
And can you share any updates regarding recent diagnoses of people with CF with COVID-19?
Yeah, so actually it's most of the solid information at this point is coming from the European Cystic Fibrosis Society, which is collecting data from 35 countries now, very impressive effort. And cases have been reported from 13 of those 35 countries. So as of May 27th update, they had 79 cases of people with CF who have also been diagnosed with COVID-19. Of those, 3 have died, 6 have been in the intensive care unit, and 16 have been children under the age of 18. And when you look at the age distribution, it's interesting, it peaks between the ages of 30 and 49. And interestingly, in some areas of the US, like where we are in the Bay Area, my institution, we also see a younger age group than's been sort of in the media, where it's always been emphasized that it's people over 65 or 70. Yes, they're at the highest risk for death, but in terms of hospitalization, the peak in this area also seems to be around 50. So it's been dropping. That's something for people to note. And of course, there's been more recognition of these syndromes in kids with multiple inflammatory phenomena in their blood vessels as a new manifestation of it. Most of the cases in Europe, actually the FPV1s have been well preserved, greater than 70%. 21 of their 79 cases had that range, and only 13 of the 79 were in the severe category. So catching the disease and is not necessarily related to the baseline status of your CF, at least in terms of lung disease. 18 of those cases did have diabetes, CF-related diabetes. So that does seem to be holding up, perhaps as a risk factor in CF as well as in the general population. And 8 of the patients were transplant recipients. One of the 3 deaths was in a transplant recipient. The majority of those cases were hospitalized. 41 of the 79 cases did need to be hospitalized, but interestingly, only 1 needed mechanical ventilation and 1 needed ECMO, which is a really extraordinary ICU maneuver for lungs that have failed. So overall, most of the folks that even needed hospitalization did reasonably well. And I think that is very good news. 48 of the cases have been characterized as fully recovered, discharged, and 15 as of May 27th were still ongoing. So that basically is a summary of the European information. The Cystic Fibrosis Foundation, last data I have is from May 21st. We should get another report later this week, but as of May 21st, 40 cases, 8 children, 15 of the 40 requiring hospitalization, 2 deaths in the US, 1 from a transplant recipient. 5 of those 40 cases were transplant recipients. So overall, low numbers, and as we've said previously, I think it does reflect good preventative measures within the community.
It's like, well, first of all, yes, absolutely. I feel like the things we've held near and dear in life practices for hygiene and infection control have certainly helped us, but it is so encouraging to see the survival rates for those who have been diagnosed, because I can say as the mother of someone with CF, I mean, it just, the thought of the potential damage. So I think it is at least encouraging to know that.
The only other comment I'd add to that is we brought up the question of the impact of Trikafta on all this. In most European countries, it's still not available. And yet their survival rates, you know, at least in this cohort, look just as good as the US. So I'm thinking that it may not be the key factor. It's really probably the fact that CF per se doesn't necessarily make for a poorer outcome if you do catch this infection.
Question was submitted. There has been talk about getting a vaccine ready for everybody in the US by January. Can you share any current information on the development of a vaccine and/or treatments for COVID-19?
Yeah, that is something that's moving with incredible speed. The government calls it Warp Speed, the name of their project, you may know. And it is true. This is really quite extraordinary. There are now 10 different vaccines that have already started human trials, which is pretty extraordinary. 5 of those are in China. And in China, they take a more conservative, or perhaps one would say easier approach to use what's called an inactivated viral vaccine. They're just different ways that they do that, and different companies or institutions that are, you know, developing their own vaccine, but they all use this inactivated vaccine strategy, which basically exposes you to the whole virus. It's interesting that in the United States and Europe, more high-tech approach has been taken, and all the vaccines that have at least now gotten into clinical trials are based on more modern or novel technologies like DNA vaccine, messenger RNA vaccine, non-replicating viral vector vaccine with proteins put into it, recombinant proteins. So we'll see what happens in the end. And I'm a little bit worried that it might be the most conservative approach that will work the best. So we have to keep an eye on that. We don't know yet how all this is going to pan out, but some of these trials have now started to move into phase 2. And things are moving very quickly. Whether it'll be under a year or not is hard to say still.
And in light of all the footage we saw post Memorial Day weekend, I hope we can convince all those people to have a vaccine once one is available.
Yeah, one of the questions that I think is still in my mind is whether or not any of the vaccines will result in what's called challenge trials, where volunteers will, after getting the vaccine, will consent to being actually challenged with the virus, with the SARS-CoV-2. The more I read about it, the warmer I get about this idea, because I do think that ethically one can justify the risks in terms of the benefits to society. So it's a very altruistic thing to think about. Yeah. And we'll see if that happens with any of these.
Assuming someone with CF might be able to get into a vaccine trial, are there extra concerns about vaccines in development interacting with CF in some way? On the other hand, if no one with CF or any health issues can get into the trials, how will we know the vaccine is safe and effective in our population?
Yeah, that is really a great question. And again, I don't think it's an easy answer. When we think about drug trials in CF, and I've done many of them, we always start with healthy volunteers and then we move into CF patients after that, because we want to see if the drug specifically has the same side effects in CF or the same efficacy that we expect it to have when we start looking at that. So I think vaccines are similar in that way. And I think on balance, it makes sense for people with CF who are otherwise doing well to be included in such trials, because otherwise we won't have any of that information. And people will be basically subjecting themselves to unknown risks after the vaccine becomes available. I think it's better to gather that information. I think it's unlikely that people with CF will have a higher adverse event reaction rate to any of these vaccines, because people with CF, unless you have a transplant, are not immunosuppressed. In fact, the immune system in CF is pretty revved up. So hopefully that will not result in any more problems, and we'll be able to get a safety profile. But it is important to find out how the vaccine works in all types of folks. It leads to a larger question of how these trials are going to be designed. If we, for example, know that older people, African Americans, people with high body mass indexes, there are various risk factors, right? Those people need to be included in these vaccine trials too, so we have a really balanced idea. And that's one of the challenges in terms of going forward, in terms of the larger phase 2 and especially the phase 3 trials of these vaccines as they come through development.
And who determines whether or not those populations can be included?
That is going to be up to the sponsors, developers, and any governmental partners who are doing those trials. So some of these are purely private efforts. We also have public-private partnerships. For example, Moderna working with the NIH. So presumably the public sector will have input into the design of those also, although I'm not sure about that. So it's going to be variable. But hopefully anybody that's pursuing a vaccine will understand that for it to really work, they need to know, is it going to work if we go to nursing homes and give this to people in nursing homes? Is that going to be safe and effective as it is for a 25-year-old? So all those things have to be factored into the next very interesting year or so of development of these vaccines.
So is that an area where members of the CF community would be able to express their hopes to the NIH, or is there any area where people can advocate to have participation by our community?
That's a good point. I think in general, if someone is interested, they should probably be in touch with the sponsor or developer of that vaccine. And in the States, we have a number of the big players, including Pfizer, Johnson & Johnson, Merck, but we also have smaller companies like Moderna, Inovio, and Novavax. So the best thing to do, I think, is once you read in the paper that something's actually gotten off the ground, if you're interested, to just be in touch with them. They all have contact information, and see what the story is and see how willing they are to include that person as a potential subject.
That just little fire for me, do a little research in terms of what I can do to help share that information with people.
And there are a couple caveats also, which I think would come out of a discussion with whoever the chief medical officer in charge of the trial at that place would be. You know, if you've had a transplant, obviously, no, you shouldn't do it. If you're on immunosuppressive medication, high doses of chronic steroids or other immunosuppressive medications, might think about it twice if you have a very aggressive type of infection. So I think those are individual considerations that people should keep in mind. And of course, if you have advanced lung disease and on a transplant list, it probably is not a good idea either. So with those caveats, I think it's important to be considered like other people as potential candidates.
Next question, a triple combo antiviral treatment of interferon beta-1, lopinavir,
Yes, you nailed
ritonavir,
it.
ritonavir, and ribavirin,
Yeah.
Has been found to assist recovery of COVID-19. Can you tell us more about this?
Sure. So there was a trial in China of lopinavir and ritonavir, which is a combination medicine used for HIV. It's an antiviral. And that by itself did not show much of an impact. So there's now a trial in Hong Kong combining these this combination of two meds plus ribavirin, which is another antiviral, and interferon beta-1, which is a immunomodulator. It's a natural body chemical that helps fight off viral infections. So the idea is if we put these things together, we may get a better effect. And that trial has been reported, and in that trial, the outcome that they found was that there was a faster recovery in terms of viral shedding in those that received the triple whammy combination compared to those that just got lopinavir-ritonavir combination. So 4 drugs better than 2 in this particular trial. But it was a very small trial, just about 85 in the triple and 40 in the comparison group. And there wasn't a clinical outcome, it was just viral shedding that they used as their primary outcome measure. So the general idea is that combination antiviral therapy may be more effective than single drug. And that makes some sense because the viruses do mutate to become resistant to single combinations. That's why the cocktail for HIV was developed, because of that need to do that and be more effective. So I think we may see a similar thing. At this point, it's too early to know if that's going to be helpful. Now, we do know that the single drug Remdisivir does have clinical benefit in terms of shortened hospitalization and a trend towards less death, although the trial was stopped because of that positive hospitalization trend before they had the power to see a statistically significant reduction in the death rate. But the death rate was quite a bit lower in people that got Remdisivir. Now, Remdesivir at this point is just for hospitalized patients because it's an IV drug. So you have to be in the hospital to receive it, and you need to get it for at least 5 days. And in this particular trial that the NIH did, it was 10 days. So we don't yet have an outpatient antiviral that looks effective. That's a very important piece of this.
And it's interesting because the next question was all about Remdisivir. So you answered most of that question already, which is great. How does the drug work? What evidence supports its use? What side effects it may have? Are there other negative clinical impacts from using it?
So Remdesivir was developed for SARS and Ebola and had some effects, but it was never widely used because they went away. They were less contagious and control efforts worked there in those cases. It does have some side effects, nausea and vomiting in some people, and it can increase liver enzymes in some people. So it's not side effect free. And in terms of how it works, it's basically tricks the virus into not being able to replicate itself. Because what it does, it kind of sneaks itself in as a Trojan horse nucleoside or a piece of the viral's RNA. So as the virus is trying to replicate itself, it slips in this analog for one of the normal building blocks and stops the replication at that point. So, but the virus can mutate to become resistant to it. So that's always a concern.
Are there any known issues with CF and antiviral drugs? With all the talk about hydroxychloroquine, I wonder if there are additional risks for people with CF who take it.
I don't think so. If you remember about flu, many people with CF take Tamiflu, for example, if they come down with the flu, if they can get to it by 2 days or so after their infection starts. So there's a pretty wide experience that antivirals in general can be safe and effective in folks with CF. Of course, each one would need to be looked at specifically, but in general, I think there's probably not an issue there. That's a good sign, because I think we'll be using more antivirals in CF as we go forward.
Next question. I am a 65-year-old with CF. I also have an undifferentiated connective tissue disease for which I take Plaquenil. 2 years ago, I was diagnosed with MOG antibody disease, a demyelinating disorder. Has anyone suggested that people like me should stay in quarantine until a vaccine is available? I live alone and miss being around people, but surely don't want to aggravate any of my disease.
Right, so this person is taking Plaquenil, which is hydroxychloroquine. That's the brand name in the US. So, and there are people that take Plaquenil or hydroxychloroquine for other autoimmune diseases. And like lupus, of course, and some patients with arthritis, rheumatoid arthritis, and in general, they tolerate it fairly well. And we know that the drug is widely used for malaria also. Having said that, there are these dangers of Plaquenil. In fact, the World Health Organization has stopped using it in their multinational trial because of an excess of deaths, which has also been noticed in the Veterans Administration trial here in the States. So despite whatever pushing there's been to use it, it is a dangerous drug in patients who are sick with COVID. We still don't know if it might be effective in preventing getting the disease or making it milder if you take it before you're hospitalized. So those trials are ongoing. So I would say the definitive total answer is not in, but in terms of sicker patients, it's not being helpful, and more people are holding off using it. The questioner is whether that person should stay in quarantine until a vaccine is available in the presence of all these problems. And I think that is a situation where you do want to be as careful as possible, but not live in a complete bubble. If you do take the real good precautions, hand washing, masking outside, the 6-foot rule, trying to make most interactions outdoors when possible if there's groups, and doing all those other things, the risk is very low. So I don't think anyone needs to be in a complete cocoon, but they do have to be careful if they are very vulnerable and make sure that they're doing all the things that we have learned are really helpful in reducing transmission of this virus.
I understand that there are only 2 types of COVID-19 tests, serology tests and viral tests. What is the purpose of having 2 types of tests, and which one would you recommend? Do these tests have different limitations or identify the presence of this virus differently?
Very complicated question, or series of questions. First of all, there's actually 3 different tests, because besides the viral genetic test, the PCR test, and the antibody test, there's also something called an antigen test, where you can detect a protein. And those can be made into kits that are very rapid. And some people use them. They're decent screening if they're positive. If they're negative, they're much less useful, these antigen tests. The PCR test, if done properly, has a very high accuracy, and in fact can pick up positives in people that are no longer transmitting or able to transmit the virus. Because if you think about it, just dead pieces of genetic material can trigger a positive test. So it's quite sensitive, and it's useful, and that's the main test for diagnosis. That leaves the antibody tests, and we've talked about this, on a couple occasions in the past. Luckily, the CDC just recently has put out a guidance on antibody tests. So if you go to the CDC website, you can find a very detailed sort of summary of where we're at with these antibody tests. What they're recommending is if the disease has a low prevalence in your area, let's take Santa Clara County where we are as an example. An antibody survey done here showed that about 2%, this was now about a month ago, so it may have changed. But a month ago, about 2% of the population tested positive based on a sample of people that responded to a Facebook ad. So there was questions about that. Who were the kind of people that respond to a Facebook ad, et cetera, et cetera. But anyway, if you take the 2% figure, even a test that is 95% accurate is still going to have more false positives than negatives. If the prevalence goes up to say 30 or 40%, the test becomes much better. So the accuracy of the test, unfortunately, depends on how prevalent the actual disease in your area. Bottom line is the CDC is recommending that if your test is, whatever your test result is, it's more accurate if you do it twice. And the most accurate way you could do it would be to do one test and then do use a second methodology for the second test or second kit. And they call that orthogonal testing, so duplicate testing. Short of that, it should not be used for diagnosis because of the inaccuracy issue based on the prevalence of the disease at the time the test is done. So it's a somewhat difficult area. I've talked before about the fact that some of these tests are kits that are less accurate than the so-called ELISA test, which is a lab-based test, and the neutralization test, which is the one that people really look at for the kinds of antibodies that may be really protective in conferring immunity. Those are much more difficult to do, and those are not only lab-based, but they're often research lab-based because they're so complicated. They involve, using cell cultures to see if the virus is still virus is still able to infect in the presence of that antibody. So the antibody story is the most complex of those.
So in terms of diagnosis, if there are these different types of tests, is there a way that should people ask in advance where they were, if they were planning to be tested, can you find out in advance what tests they use? And if so, then you would say the PCR test would be the...
Yes, I think if people are symptomatic or have contacts and they're concerned about, have I picked up this virus, the test to do is the PCR test. If you've had the disease or if you've been in contact with, let's say you're a caregiver or a household contact of a person that's had it, and you want to know if you're immune, if you picked it up, then you can do the antibody test. Remember, it takes about 3 weeks for the antibody test to be reliable because it takes some time for the immune system to rev up and make those antibodies. So they're answering sort of different questions, and a lot of epidemiologists will use both PCR testing and antibody testing to get a good picture of what's going on. And then finally, these antigen tests can be used as a screening test, but again, backed up by the PCR test to be more accurate.
I've heard there's a correlation in outcomes when people are infected with a small viral load compared to patients infected with a large viral load. Patients infected with a smaller initial viral load seem to do better. Is this correct? And why does this make a difference?
Right, so this is a very good point that is often missed in the discussion. And I think this relates to the issue of indoors versus outdoors, because if you're exposed outdoors and the air can disperse very easily, you're liable to get a much lower dose, even if you're next to the same person that, let's say you're in a room versus the beach. Same person, same distance, same time of contact. You're going to get less exposure outdoors because it's more dispersion. Does that relate to whether you'll get sick or how sick you'll get? There is a correlation there. So people in China have looked at that. They've done testing what's called the viral load. So they basically are able to quantify how much virus you have in a sample, whether it's in a nasal sample or in a bronchial lavage sample, blood, stool. They all can be positive. And what they found was that the higher the viral load, the sicker the person and the longer it took to recover. So the answer there is yes, there is a relationship, which makes sense. The bigger the dose you get, the more likely it is to have an adverse effect on you. So in general, I think that makes a lot of sense. And it does also, it contribute to understanding why being outdoors, for example, as lockdowns come down and you start gathering in groups, much safer to do it outdoors with some distancing and masking than if you're in a room. All those things to consider. If you're in a room, how well ventilated is it? Ventilation matters too. All those things play into this idea of dose exposure.
Has anybody done studies with HEPA filters and the ability to clear the virus?
Most of that work has been done with the N95 masks, right? So those are tested rigorously for that kind of thing. HEPA filters like you'd use for allergies, I haven't seen actual studies of whether they do anything for this. It's an interesting question. I haven't seen anything on it.
But it certainly does speak in terms of viral load about just the incredible risks for healthcare providers who are indoors. Just
right. Most hospitals have put patients in negative pressure situations, so they're actually sucking the virus out of the air to prevent exposure, if they can, if those facilities are available.
Next question. We have a child with CF and believe that she, as well as others in our household, may have either had or have been exposed to COVID-19. After hearing about all the problems with antibody testing, is it worth it to get anybody tested? Can we trust the results? Furthermore, if we knew we have the antibodies, would that mean that we have a defense against this virus and can relax our strict quarantine measures?
So the CDC has been very clear on this. You should not use the antibody test result to guide what you do, period, end of story, for the reasons we've just been talking about. So it is useful to find, at least for me, it would be useful to find out what kind of antibody test was done. And it is useful to know if you've developed antibodies, especially if you're a contact of a person that has had it. Most people that have do develop antibodies after 2 or 3 weeks. It's less clear whether contacts will develop antibodies. So at some point that does help, I think, to know that your risk is lower, but it doesn't mean you can discard the measures that are in place in terms of public health measures that we've talked about. So maybe we'll get there at some point, but we're not there yet in terms of how the antibody tests are used. They have more of an epidemiologic role than an actual guidance role for an individual.
I've heard about correlations between higher vitamin D levels and better health outcomes in folks facing COVID-19. Can you please discuss the validity of this correlation and explain why vitamin D helps folks with COVID-19? For those of us in the CF community, would vitamin D possibly improve our odds or help to keep us relatively safe?
Yeah, well, this is another example of where we're out ahead of the rest of the world, because we've been testing for vitamin D levels in the CF community for years as part of the annual evaluation at most CF centers. And we strive to make sure that people have good stores of vitamin D and put a lot of folks on supplementation to try and achieve that. Now, why is that important? In general, vitamin D is useful in terms of immune system health. And that's one of the reasons people are concerned about it in terms of COVID. The other piece of it is if you look at the epidemiology and you see where this disease is hit harder, Northern Hemisphere, at least so far, more than the Southern Hemisphere. Well, that's changing now with Brazil, right? And India, other places. But at least for the first few months, the Northern Hemisphere has been hit much harder. And in general, vitamin D levels are lower in the temperate than in the tropical regions. And also in terms of the propensity for the disease to be worse in people of darker skin, that's also related to lower vitamin D levels. Those are just associations, so it's not clear whether supplementing vitamin D, improving vitamin D levels will actually make a difference. There are studies that have now been started primarily in the UK that I know of, to look at that question in very large groups of people. So within a few months, we actually may have some data, but right now we don't have an answer on that. But it won't hurt to be vitamin D replete. So luckily, folks with CF, you should know your vitamin D level. It's there on your medical record. So if you're low, you should get supplemented up to a good level. We strive for a level of 30 or higher.
That was a great question. Very, very linked to our community, something I hadn't thought about. Do you anticipate a larger amount of CF exacerbations in our community, especially pediatrics, due to the shift in care that we are receiving now with being unable to come in and have PFTs, and also to do the sputum cultures with patients? And it seems while patients are a lower priority, do you think that this will then translate to more exacerbations?
Well, that's a hard one to answer because we don't know how things will turn out. I mentioned before the concerns about the upcoming flu season and making sure that everybody gets their flu vaccines to try and reduce their susceptibility to co-infection. Getting sick and having exacerbation that also might be complicated by COVID. In terms of the delivery of care, it's true that many CF centers have gone to telehealth, at least temporarily, and our clinic is just now shifting back to in-person visits. There are many concerns to address. One of them, PFTs, is a big one because we have to develop a proper protocol to make that safe for everyone. So at least for a period, less PFTs have been conducted. One thing to think about in terms of dealing with that situation is having a home spirometer. And in fact, there are a number of good home spirometers that are available. So if someone is kind of missing getting their PFTs done and their center is not able to sort of reinstitute that in a timely fashion, you might consider that. And I think the CF Foundation is providing some support for that, for people that want to look into that. Whether or not there'll be more exacerbations sort of aligns with the fact that people are very concerned that other health concerns in the general population are happening without being addressed. So childhood immunizations have fallen, rates of other diseases like heart attacks resulting in ER visits have fallen. Undoubtedly, people are staying away from facilities because they're scared of picking up the virus. So many facilities are doing their best to put into place or have put into place protocols to minimize that danger. And by this month, most places have achieved that, I think. So hopefully people can resume their normal care. So going forward, I would hope that there wouldn't be any uptick in exacerbations or missed exacerbations, late diagnoses, et cetera, because of that. A lot depends on whether there's a second wave and whether people go into lockdown or not. So that relates to the effect that the opening is going to have over the next few months. I'm very concerned, as many people are, that there's going to be another, at least uptick, if not wave. And in many places, the public health authorities are going to, pull back again. So this could be an ongoing problem. And it's just something that I think people will need to be creative in terms of how they're relating to their providers and making sure that their care does not suffer because of fear or any restrictions on visits.
So the same person wanted to know, do you anticipate when CF clinics open back up that there will be, for not telehealth appointments, but in-person appointments, that there will be greater wait time to get an appointment because everyone will be making appointments at the same time?
There may be a bit of a backlog, but I honestly don't see that as a major problem.
Do you see, this person had 3 questions, so I'll just keep linking. Do you see the above issues as things that need solutions now, or is it just a hidden side effect of a pandemic? And unfortunately, we just have to do the best we can in these unprecedented circumstances.
I can only answer for my institution because I don't know about others, at least in any detail, but at Stanford Healthcare and at Stanford Children's Health, people have been working very hard on this for 3 months. And essentially, things are either fully back to the way they were or on their road there with a lot of protocols in place to make sure that all the elements for safety are there, both for the patients that come in and for the healthcare workers involved. And obviously, it's taken a huge amount of work on many people's part because there's so many moving pieces to this, right? So every little procedure, every little thing that goes on has to be checked out from A to Z to make sure that whatever's possible to put into place has been done.
So the last question on the list, what options are there for contact tracing with COVID-19 and how can we participate? Which organization is responsible for the information gathered by this and how is this information transparent or released in real time to help protect the community?
That's a great question and it's crucial. You know, test, yes, but without follow-up, it doesn't mean anything. And the follow-up is the contact tracing. And that requires work by people. The only alternative is the tech alternative, which some have suggested using smartphone geolocation data. That raises civil liberties issues and probably won't fly in the US, although if you read about what they do in China, it is completely based on smartphone data that they use to basically track people. And they give you a green, yellow, and red light on your smartphone, depending on whether or not you're okay to go into that store or buy in that supermarket or go to that school. It's unbelievable, but this is not something that I think is going to be adapted in the United States. So we're left with people primarily, I think. Even though Apple and Google are working on technology, I do think this is going to be a people problem. And that means a lot of people. It's been estimated that we probably need about 100,000 contact tracers in the country to really get a grasp of the problem, and we only have a fraction of that. So this is under local control, primarily county level. So the governor of California, Gavin Newsom, has initiated a program called California Connected, which is the contact tracing program. And they are looking for people who want to become contact tracers. And in fact, people that have lost employment because of this. This is something where you could get a good job and do some good and actually, you know, stay above board, stay afloat. So if you go to either the state website, there's a California Connected website, there's a covid19.ca.gov/contact tracing. These are two different websites that will both lead you into that, or through your just local county public health website. Basically, every county is going to be hiring people to do contact tracing. And it's a big ramp-up effort that's begun. I think the governor said that there's currently, the goal is 10,000 by a certain date in a few weeks, and ultimately 15,000 contact tracers in California. Hopefully that will be able, you know, through the summer to ramp up to a point where we can actually stay on top of outbreaks and clusters and shut this thing down. But it's going to take a huge number of people to do that. And that is the problem.
And so for people in other states, is the funding for this coming from is it federal funding or is it each state is making their own?
I think it is all through state funding into the counties and not a lot of federal support, like a lot of other aspects of this pandemic. The federal government has said it's, you know, it's on you. So that's where the action is.
It's so unfortunate, obviously, on so many levels, but especially with the states, you can see some have had very different philosophies about sheltering in place and reopening their economies. So if
we're all over the map. I think the last count was 24 states where case loads are still increasing. They're not on the downward slope at all, and they've still opened up to some degree. So how that pans out is a very local issue, and people in each locality are going to need to just keep track of that. At the end of the day, no one can force you to go to a restaurant or you know, into a grocery store if they're not doing the right kind of things and if you don't feel comfortable enough. So this is not something that I think any government at any level is going to be able to impose one way or the other. It's going to be guided by people's understanding of the risks and their feeling of safety in doing a particular activity or getting back together with other folks.
Mm-hmm. Well, sadly, that was the last question on that list. And
let's see how this goes over the next few weeks and months, and you know, hopefully we'll be able to, as a country and also in our area, to stay on top of the problem. We'll be seeing some new treatments. Some of these big drug trials will be coming to fruition within weeks to months, and the vaccine efforts are going to continue to move forward very rapidly. So I think it's a hopeful time, but we have to be really cautious.
Well, I thank everybody in the community that has submitted literally hundreds of questions through these weeks. And I thank you, Dr. Moss. Between the community and your expertise, I have learned so much about COVID-19, and this truly has been a gift.
I hope it's been useful. Thanks.
It has been very useful. And for those of you who, like me, will miss these weekly sessions, if you do have a question that you would like to have answered, please send it to cfri@cfri.org, and we'll select a question or two or three and address them in the e-newsletter. So Dr. Moss has kindly offered to still be on call for key questions, so please don't hesitate if you do have something that you really wish to have addressed. So with that, I thank everybody for being a part of this incredible 10-week series, and I thank you, Dr. Moss.
Thank you.
Bye-bye.
Bye-bye.